We have the next speaker from Melbourne, Dr. James Elder, and he has a lot of surgical experience in all aspects of pediatric ophthalmology and strabismus, including and particularly cataract, glaucoma, oculoplasty, and retinoblastoma. So we'll hear him talk about screening and prevention of ROP.
Thank you for inviting me to talk in this session. There's sort of a change of pace here because this is more about hospital systems and protocols and things of that nature rather than exactly what the ophthalmologist does. So we all know that ROP is a disease of retinal angiogenesis that's seen in some premature infants. Basically, you can think of it as a VEGF gradient that encourages the growth of blood vessels. And because when children are born premature, their vasculature is immature, we see this problem. Originally, we only recognised the end state of this with a totally detached and scarred retina, and it was some time before the vascular nature of this disorder was seen. Very early on, the risk factors were identified. It used to be called the Boston disease when it was first identified in the US. And one of the things that stands out in the notes of the first patient identified as having retrolental fibroplasia is that they had constant oxygen and completely unmonitored. And so that tells us very much what one of the major risk factors are. So what are the risk factors for prematurity? The degree of prematurity is important. I'm not sure what everyone else's experience is at the moment, but I'm starting to see babies of 22 weeks gestation considered to be salvageable, and they have an incredibly high risk of retinopathy at prematurity. So there's this inverse relationship between gestational age and birth weight and the risk of ROP. Oxygen therapy, and particularly how it's administered early on and the dosages and the saturations that are aimed for a little later. Poor weight gain is another big risk factor. There are a whole lot of others that are not quite so relevant. Prevention, this is really where it broadens. It's a whole of health system thing, so it's avoid, minimise premature birth, and that's nothing to do with you or me. Optimise the fetus prior to delivery. Again, that's nothing to do with you or me, but incredibly important to what we do. And then optimise the care of the premature infant following preterm birth. And then again, that's not you or me. This cartoon goes over some of the things that you can do to look at prevent preterm birth. Things to do with family planning, antenatal care, the management of labour, to use tocolytics to delay premature labour, give steroids at that stage so to increase lung maturation, and I'll talk a little bit more about that. So there's a whole host of things here. Most of these are managed by obstetricians or public health and things like that, but they're incredibly important for what we do looking after ROP. Again, there's specific measures here that are just outlined. Corticosteroid deliveries during premature labour are very important to mature the lung, and the tocolytic agents just give those steroids time to work. There's a nice, a few years old paper that just summarises this thing, points of care, in the things that are really important in caring for a premature baby. Pain control, oxygen management, and this is really interesting. These are the target saturations that the neonatologist should be looking at certain periods after birth. And so not all premature children should be given 100% oxygen at birth. They should be managed with CPAP and then given oxygen if they fail to meet those things. And those sorts of things of too much oxygen early on probably unleash a cascade of things that increases our risk of severe ROP. And there's the other factors that the neonatologists do with nutrition and temperature control, etc. We know from several large randomised trials that were done that what target saturations we should be aiming at once the child is in the nursery, and basically they're in the low 90s are very important. Screening. Now, the slide, just as a principle of screening, we don't need to read it from front to back, but ROP ticks all the boxes. We have a captive audience, we understand the disease, it's acceptable to the population, and we have good treatments. And so the challenges, not so much is screening worthwhile, but how do we do that? We need a common language, which we have. We need guidelines and service provision, and these are whole of health system organisational things, that some of which are not necessarily under the control of an ophthalmologist. The common language is ICROP. ICROP 3 is what enables us to look at that photograph, and in a baby of 32 weeks post-gestational age that was born at 22 weeks plus 3 days, and last week the fundus looked pretty normal, tells us that that's AROP. That's the AROP that we see in countries where they're extremely premature babies rather than problems with oxygen toxicity, AROP, or sick baby AROP, as it were, where it often is more peripheral. And so we know that, I'm not going to go into details of that, but they're all the things that are covered in ICROP 3. I guess the things that are new and important there are related to regression and reactivation, particularly in the era of using VEGF inhibitors, which has become much, much more common. So guidelines, and this is guidelines for the ophthalmologist and the units where these are managed, and they need to be evidence-based, and they need all these things need to be maintained and kept up to date. There are a variety of different screening guidelines. Obviously, there's the American Academy of Ophthalmology and Pediatrics, and they should have regional variations. They can't be one size fit all. We shouldn't all use the American Academies because they're good, because they won't fit certain population groups. Now, I'm sorry if this one I've got here for retinopathy of prematurity for India is out of date. It's some years old, but you know, their cut-off for babies they look at was 2,000 grams or 34 weeks, whereas in Australia and New Zealand we've just revised our guidelines. Most units use 1,250 grams in 30 weeks, some units a little bit larger, and a recent publication from Ethiopia has come up with what their recommendations are. So all of these are regionally and institutional specific. Guidelines need to cover a whole lot of different things that tell everyone what they need to do, because, as I said, it's a whole of system thing. If the neonatologist doesn't tell us to see a prem baby, they'll be missed and they might go blind. And so these guidelines need to cover everyone's responsibility to make sure that all of the right children are seen at the right time by the right person. And I'm just going to highlight some of the points, and this is and some of that is there as the responsibilities of the different teams. I'm just going to highlight some of the features from our Australian guidelines. So there are some evidence-based guidelines as to when to start screening, and we follow those. The method of examination, now that's pretty universal as to how that's done, but these days obviously a lot of wide field digital photography is used, and we're very familiar with that in India. Important features here are pain control. Pain control is always important for a premature infant, and it's one of the things that gives a better outcome. So sucrose, topical anaesthesia. Infant monitoring to make sure that they're stable during the is not the responsibility of the ophthalmologist. Which children require treatments? Well, that's really covered in ICROP, type 1 and AROP. The timing of treatment needs to be specified in your policy. And this other thing of looking at the responsibilities of the different people involved in this care. So our guidelines clearly specify what are the responsibilities of the neonatal team, the ophthalmology team, and also more widely the organisation. The institution has to support this and fund these things and make sure there are appropriate people available. We have laser standards for the children that need laser and things like that. So, in conclusion, I'd like to say there needs to be a common purpose that's organisational-wide and indeed wider public health right to reduce the incidence of premature birth, provide optimal care for those children, enable screening that's timely and to those children that are high at risk, and ensure that the children that are at risk of visual loss, which are the children with type 1 and AROP, that they get care when they need it. I haven't said anything about follow-up here, but follow-up is obviously an important feature of this because these children are prone to other problems, refractive error and strabismus, as well as their retinal morbidity. And it really stresses that it's a whole of healthcare system input required to get the best outcome for these children in terms of prevention and screening. Thank you.